Hello, everybody. Good evening. Welcome, everybody, to a beautiful discussion today on this August Thursday evening regarding a very, very important topic that I think everybody needs to talk a little bit more about, which is organ donation. So, I think without wasting much time, I would request Dr. Rajesh to introduce everybody and then we can take it further because I think it's a long night, it's a long evening full of a lot of questions, a lot of debate, a lot of discussions about the various aspects of organ donation and how this important aspect is going to impact the lives of so many of our patients suffering from end stage lung diseases. So, can we have Rajesh's video, please?
Hello, dear friends, and a good evening to all of you, and a warm welcome on this Thursday evening for another edition of a webinar from CCI. And this time, as we are commemorating the Organ Donation Month, we are bringing to you for discussion the topic of organ donation, its harvesting, and how to increase the awareness of this organ donation, which is very dismal in our country. So we cannot avoid death, neither we can run away from death. But a person can save another person's life by pledging his or her organs for organ donation. So, organ failure has been one of the leading morbidities with more lives lost in the pandemic and in the past that we have all experienced. Many needy patients lose their lives because of the lack of organ availability. But there is a one initiative that can save up to 8 or 9 lives because of the donating the heart, the kidneys, the pancreas, lungs, liver, intestine, hands, faces, tissue, bone marrow, and now even the stem cells. We all need to be committed for organ donation because, as per the Indian Ministry's health estimation, about 1,75,000 kidneys, about 50,000 livers, hearts, and lungs, and 2,500 pancreas are needed to meet the demand. India had reported only 1,137 more deceased organ transplant in kidneys during the last year, and if I talk about the figure, there were just 759 kidney, 275 liver, and 99 heart transplant that were done. Interestingly, as per Indian Ministry of Road Transport of Highways, the 2022 report, more than 2 lakhs were reported as accident-related mortalities. However, to our disappointment, only 752 deceased brain deaths organ transplantation were done as per this report of 2022 of National Organ Donation. So this is a dismal rate of less than 1 per 10 lakh people in this deceased donors. And this has been relatively constant figure as I was seeing the figures of last decade from 2013. While we all need an estimated 62 per 10 lakh population of deceased donors to become to just let India become organ donation self-sufficient. So, what are the challenges in India about organ donation in general and lung transplantation to be specific? Why we are so behind globally in organ donation? Well, there is no other time than this to discuss this when we are observing Organ Donation Month in India, which started being commemorated after India's first successful deceased donor heart transplant in August of 1994. So, well, friends, as usual, in CCI, we have a team of eminent panelists, eminent people who will give talk, and this includes today a medical legal expert, transplant surgeon, transplant pulmonologist, who will drive this discussion and clear our understanding about the subject. So it is my absolute pleasure to introduce them to you, and let me share the slides of introduction of this eminent jury or debaters or panelists that we have today. And uh, we have, as we all know him, Dr. Apar Jindal, who's clinical director and consultant Department of Lung Transplant and Interventional Pulmonology and Respiratory Medicine at MGM Healthcare. He's a renowned, as we all know, and experienced profession in the field of lung transplant, having successfully managed over 300 cases with exceptional expertise in pre, post, and long term patient care. He's an accomplished specialist in advanced lung failure management with a particular focus on patient requirement in requiring ventilatory and ECMO support. Dr. Jindal has played a significant role in facilitating air transfers of ECMO patients from all over the country, and I remember one also from Nagpur during the pandemic, and has an outstanding track record of saving lives. So, Apar, welcome to this webinar. Glad to have you here. Then we have Dr. Harshvardhan Puri, who's the country's first board certified gold medalist thoracic surgeon, who's working as a senior consultant in Institute of Chest Surgery, Medanta, the Medicity. You know that this is the largest department of chest surgery and lung transplant in India. He has done his super specialty masters in thoracic surgery and lung transplantation training from Toronto General Hospital, Canada. He's also the gold medalist in the field. He is thoroughly trained in advanced thoracic surgery, VATS, robotic thoracic surgery, and lung transplant by the pioneers in the field of lung transplantation. He's a young and vibrant thoracic surgeon with a pleasant demeanor, a person who exhibits great commitment and diligence in his work. He has been part of more than 10,000 thoracic surgical procedures in a career spanning more than 12 years in the field of thoracic surgery. He has made humble contribution to the field of thoracic surgery by authoring many original articles in reputed journals about the topic and lecturing about this immensely difficult surgical field in many conferences in the country. He's also the chief medical advisor of Lung Care Foundation, providing lung care to about 2.6 billion lungs of India. We have a medical legal expert, which is so important in this kind of webinar, where we are actually discussing the organ transplantation of deceased and dead people. We have Dr. Shobhan Roy, who's assistant professor, Department of Forensic Medicine and Toxicology in Deben Mahanta Government Medical College and Hospital, Hatwara in Purulia, West Bengal. He's also a member, he's MD Forensic Medicine. He's member of Institutional Ethics Committee and also a nodal officer of Organ Tissue Transplantation Organization or NOTO at DMGMCH Purulia. So it will be an immense contribution of him in this webinar, and I welcome him. We have another young transplant pulmonologist, Dr. Unmil Shah, who's a consultant transplant pulmonologist at Sarach and Reliance Foundation Hospital, Mumbai. He has a rich experience of more than a decade in the field of pulmonology. He has a vast experience of transplant pulmonology in terms of perioperative care, bronchoscopic intervention, long-term follow-up and care, donor lung optimization, retrieval, etc. He had training in interventional pulmonology from Ancona, Italy, and he has numerous publications and prestigious in the field of transplant pulmonology. We have one more young transplant pulmonologist whose biodata I will share, and he's none other than Dr. Chetan Vaddepally, who's a consultant interventional and transplant pulmonologist at Yashoda Hospitals, Hyderabad. Uh, he has his expertise in evaluation and management of patients with end-stage lung tissue, pre-transplant evaluation and post-transplant management, and an active member of various national and international pulmonology societies, and he's an interventional pulmonologist as well. So thus, we have a very eminent and luminous panel today who to discuss this organ donation. To set the ball rolling, we initially will have talk by the transplant pulmonologist Dr. Apar Jindal and transplant and lung transplant surgeon Dr. Harshvardhan Puri, who will give us a brief context about what all logistic is involved in a lung transplant. It's a scientific basis. But post that, we will have a panel discussion where we will have these panelists discuss about various challenges, what is dogging our transplant, organ transplant program in India, specific to lung transplants. And here I would like to also request our viewers that you can pose your question, doubt, or any queries regarding this lung transplant organ donation to our panelists, and we will try to take as many questions as possible from the audience to have being answered by this eminent panelist. So do put your questions in your chat box. And now to just begin, I invite Dr. Arpan Jindal and followed Dr. Harshvardhan Puri to give their brief talk, and we'll meet you past these talks and panel discussion. Thank you.
Hello, everybody. Today, it's a very, very important topic considering the changing scenarios of India, the organ donation, and we are particularly talking about the lung transplant in this forum. And I thank CCI for giving me this opportunity to speak on this so much pertinent topic, which is very important and very close to my heart. So I'll be talking about some overview of the transplantation and the donation process also. I'm Dr. Harshvardhan Puri. I'm a senior consultant chest surgeon in Medanta, the Medicity Gurugram. So greetings from my institute. So let's break the process into a few steps. First, I want to introduce, this is our team, which got trained in Toronto General Hospital for lung transplantation last year. And from that time to till today, we have done 8 transplants, and all the patients are doing good. So the lung transplant process should be broken down into referral, evaluation, listing, recipient management, donor call, donor management, explantation, implantation, and post-operative care. So whenever we get a referral from some of our friend in tier 1, tier 2 cities, the call is evaluated by a pulmonologist, a surgeon, and the patient is divided between 3 categories. That is too sick, merits evaluation, and it's too good. So if too sick, we just say that continue medical management. If he merits evaluation, he's called to Medanta Hospital, and a stay of 4 to 5 days is given to the patient, and we evaluate, which we call as on-site evaluation. So this on-site evaluation consists of around 48 to 50 tests, where all the organs are tested. And after this evaluation, a multidisciplinary team sits down and sees these investigations. They try to optimize the patient according to the flaws in the investigation. And this team finally says a yes to the transplant or a no to the transplant. If it is a yes to the transplant, then we bring the patient and the family back. There is a counseling of the patient. It goes on for an hour or so, where everything pertaining to the morbidity, the mortality, the cost factors, and everything is explained to the patient. One very important fact which is explained to the patient, that he has to live within 200 to 300 kilometers of the hospital, so that he can be called when we get an organ call. So And after that, a listing of this patient based on the priority is done on a website of Noto, which is the central agency performing the transplantation process in India. Now starts the process of recipient optimization, management, and on-site and online evaluation. The physio online daily consults are done on-site twice a week. Medical management is done by the pulmonologist. Nutrition support to the recipient is given by a dietitian, emotional by a psychiatrist, and he has to stay near the hospital. So this is one of the first patient of ours who is doing physiotherapy in our physiotherapy center on around 10 liters of oxygen. This is very important because the more you sweat in peace, the less you bleed in war. After one fine day, we get a donor call. We evaluate this call. If our recipient's lung size is matching, his blood group is matching, so we put our claim for those lungs. And now, if the lung is allocated to us, this is a WhatsApp group of Noto where this call comes, and a lot of evaluation goes before accepting these lungs. So a matching is done where a total lung capacity, volumetric matching, blood group matching, recipient's present condition is seen, and willingness to go for the transplant. If everything matches, the recipient is brought to the Medanta hospital. Now starts the race against time. In this race against time, we have to do transplantation, process of explantation and implantation in a specified period of time. So the team is divided. This is a beautiful old photograph, aadhe idhar jao, aadhe udhar jao, and the process starts. Now, what happens? Donor management, which Dr. Apar was also talking, is a very, very important part of our process. So we optimize we call up the donor hospital. We try to speak to the interventionist and start optimizing the hemodynamics. Even distribution of vasopresses is done. The fluid management, the fluids have to be kept very low because the lungs should not be wet when we are taking them. Antibiotics are optimized, Tylenol is given, and optimal ventilation strategies are laid to the donor hospital. Now starts the movement towards the explantation centers. So logistics are checked by our movement team, and checklist is made so that we can see what we have to take with us to the donor hospital. So we take everything from instruments to decks to fridges, everything is taken by Medanta hospital to the donor hospital. At the donor hospital, the first person we contact is the interventionist or the anesthetist. The lung transplant team, the surgeon and the coordinator goes for this explantation. We check all the history and documents. A checklist is given to the anesthetist who is optimizing and maintaining the patient. The gases are checked, CT scan is checked, bronchoscopy and BAL is checked. And if the P/F ratio is good, that's more than 300, we accept the lungs provisionally for explantation. After that, the patient is wheeled into the OT, where a prayer is always done by by our team or the donor hospital team for thanking this gentleman or gentle lady who has given a mahadan of life. See, there is no bigger dan than doing a organ donation or a lung donation. So we always do it. We stand there, be quiet for a minute or so, and after that minute, we start our dissection and the explantation process. The explantation is done by a sternotomy, the dissection of heart is done, assessment of lung is done, then pulmonoplegia is started by a Perfodex plus solution, explantation of heart is done. If the heart is being taken for heart transplant, it's done by the heart team, or if it is not being taken for heart transplantation, it's done by our team. And explantation of lung is done, the packing of the lungs is done inside the Perfodex solution, and then the transport. The transport is a very important thing, and what newer advance is there in transportation, which is done by Medanta Hospital, that we don't transport the lung in a ice box. We transport these lungs in a 10 degrees fridge, which is in a study being evaluated to because usually the lungs are stored in an ice box which is at 4 degrees. Now we are doing all transplantations and or transportation of these organs on 10 degrees, and it is a hypothesis which has been thoroughly proved by Toronto General Hospital that if the lungs are stored at 10 degrees, the total time of this transplantation process can be increased from 6 hours to 12 hours or 18 hours. So return journey, this is the famous green corridor, which we always get whenever we are returning from the donor hospital. We this is the race against time. We are running to the hospital because we want to reduce the ischemia time. We have this switch, but still we want to reduce the ischemia time to the minimum. After reaching the this recipient hospital, the surgery has already been started by the recipient team. I'll be talking, but one very particular experience I just want to share with the audience, that the last line which we brought from Junagadh, it was a fabulous experience. I'll show you a small video which will tell. We went there by a private jet because there was no commercial flight available there, and there was a seamless coordination between the NATO, the Gujarat government, the CISF, the Airport Authority of India, and the donor hospital. And what hospitality we got at the donor hospital, I was literally crying when I was coming out of the OR. The first person to meet us was the husband of the lady who had died. That husband touched our feet and thanked us because we are giving life to his wife who just died a few hours back, and this life will continue in our recipient when we are going for this transplantation process in our recipient. It was a fabulous experience. I've written a short write-up also. Most of my friends have got it in their mobile. So this was an experience. This showed me, this opened my eyes that organ donation is the biggest thing a person can do for his fellow human beings. Recipient surgery, I won't go into details. It's done by clamshell, bilateral dissection, pneumonectomy. We do all surgeries on ECMO these days. Implantation is done by PA, bronchus, PA, LA cuff. Then the ECMO is reduced to half after the first implantation. Then the second implantation is done and the patient is taken off ECMO if he is maintaining saturation and shifted to ICU. These are few pics I showed last time also. Skin incision, clamshell. This is the ECMO circuit, bronchial anastomosis, pulmonary artery anastomosis, LA anastomosis, and taking off ECMO. This is a specimen pic of our third recipient, the double lung transplantation for a bilateral bronchiectasis. Post-operative physiotherapy is very important. Post-operative rehabilitation in physiotherapy. This is done by our physiotherapist, Dr. Deepika, and it's an utmost important. Surgery is a very small part of transplantation process. The preparation of a patient and the post-operative care is the most important thing. And this is our first recipient after 3 months of the same guy you saw in the first video was doing this kind of physiotherapy in 10 liters. Now he's doing it without any oxygen. This is the gratification we get by transplantation. Organ donation, I'll just touch upon a few points in 1 minute. It is the biggest Mahadan which a human being can give to his fellow human being. Usually in India, donation after brain death is followed. Donation after cardiac death is now allowed because in January 2023, the legislation has completely changed. Now we can put the patient off ventilator. Visible look cardiac death can be done. So donation after cardiac death is possible now in India. Marginal donors are those donors who have who don't meet the criteria for ideal donor. Like PA by F ratio is like 260 or 270. These marginal donors should be taken with some caution and with some optimization. How to increase donors? If we can increase this marginal donor pool, the number of donations will definitely increase, and we should involve everybody, the Sarkar, the NGOs, agencies like Mohan Foundation, like hundreds of agencies working into this system, doctors, and appeal to the public that organ donation is the most important thing and the biggest thing they can do for the humanity. Marginal organ donation can be increased by using ex vivo lung perfusion, which we are going to buy in next 2 or 3 months, and the 10 degree switch, as I've shown to you in the last slides. This is the EVLP circuit, and this is the 10 degree switch which we have. So the result, this is the result. This is our first and second patient. It's so gratifying. It's so I can't tell you. This kicks us and pushes us to do these kind of things. Thanks a lot, and I'll ask everybody today to pledge their organs for donation. Thank you.
Hello, friends. Good evening. I'm Dr. Apar Jindal, Clinical Director for Lung Transplant at MGM. And today I'm going to be talking about organ donation from a pulmonologist perspective. Kudos to CCI Krishna Bhai, for thinking about organizing a CME on lung donation or organ donation per se. I think this is one of the most important topics that needs to be touched upon, creating awareness not only in the medical community, but also to spread awareness in the general population so that we have more and more people coming forward for this noble gesture. Without much further ado, I would move on into the specific aspects of organ donation, particularly related to the lung and what a physician needs to know in these aspects. I'll be talking a little bit about the pathophysiology after brain death and then move on to specifics in organ selection, contraindications, indications, criteria for organ donation, and we'll share a few slides about the standard organ management or donor management protocols, which is particularly aimed at managing or optimizing the lung health of these donors. Moving on into my presentation, I think the most important slide is this, that what is organ donation? If I can put it in one line, it is a gift of life. The gift of organ and tissue donation is the only positive experience in the tragic chain of events surrounding the loss of a loved one for the family. So whenever there is a brain death that happens to any accident victim or a cerebrovascular accident patient, if in their moment of grief and in their moment of loss, they decide to take this noble gesture, I don't think there is a bigger gift that anybody can share in this world. Why? Because this one tragedy can give 8 people their lives. Talk about lungs, talk about hearts, talk about liver, kidneys, pancreas, small bowel, and now for that matter, hands and bone as well. It's more than 8. It's now gone up to 11 lives, but definitely 8 organs can give life to people who are waiting for this gift of life because of end-stage organ disease. If we look at the data from NOTO about organ donation, we clearly see that there are highs, there are ups and downs. During COVID times, the number of donations was at its all-time low. But the sad part is that if you take a line, arbitrary line, and draw from Gujarat to Visakhapatnam, 90% of organ donations, what we see, come from South India. Very few organ donations come from the northern part. And very clearly, the data from 2022 shows that Telangana, Tamil Nadu, Karnataka, Gujarat, Maharashtra, these are the states which provide maximum number of organ donors for the rest of the country. I think the other states need to buckle up. The physicians need to take charge of this and start talking more about organ donation to different people. Now, there are 3 basic types of donors when it comes to deceased donors. 1, there is a brain dead donor. 2, there is donation after circulatory death. And the third point would be any tissue donation. What is a brain dead donor? It's basically an irreversible and a non-survivable brain injury where the patient is confirmed to be brain dead by the means of particular investigations, managed in the ICU as per the donor management protocols, and then shifted to the OR for organ recovery. Whereas if there is an irreversible, non-survivable injury and the patient has not progressed to brain death, but since it is irreversible, family wants to donate these organs, these patients in the OR undergo a supervised extubation for a cardiac standstill to occur, and then within the next 90 minutes, there is a rapid retrieval of all organs. So this is called as donation after circulatory death. And if neither of the organs, either from a brain dead donor or a circulatory dead donor, is attainable, then of course, tissue donation is still possible in some of the cases, such as bones, heart walls, skin, cornea, etc., can still be donated. Now, what to expect typically from a physiological standpoint after brain death? The first thing that happens is an autonomic or sympathetic storm that impacts the cardiovascular system, the circulatory system, and of course, the lungs. The release of catecholamines like epinephrine and norepinephrine leads to a hyperdynamic state causing tachycardia, elevated cardiac output, vasoconstriction, and hypertension. And this creates a huge roller coaster within the pathophysiology, within all the organ systems of the body. We'll just touch upon a few of them. What happens from hypothalamus failure? It results in impaired temperature regulation, which can lead to either hyperthermia or hypothermia. There is significant vasodilation without the ability to vasoconstrict or shiver, leading to because of the loss of vasomotor tone, and it leads to problems with the pituitary. Now, what are these pituitary failure? It leads to ADH, and ADH production to cease, and this is going to cause a lot of issues. The diabetes insipidus that ensues causes huge amounts of diuresis, causing a lot of fluid imbalances in the body. This leads to hypovolemia, and the fluid imbalance also causes electrolyte imbalance and can also lead to thyroid issues. Now, this hemodynamics change because of the fluid change, because of the electrolyte imbalance. There are three components to this. We've already discussed a hypovolemic component because of cerebral edema, because of DIC and hemorrhage, because of the diabetes insipidus, and because of an osmotic diuresis from the resulting hyperglycemia. But very important, other than this, there is a neurologic and there is a cardiac component as well. The neurologic because of the loss of the vasomotor tone, and the cardiogenic component because the hypothermia that comes in creates myocardial contractility dysfunction, and there is a left ventricular dysfunction because of the catecholamine storm, because of the resulting arrhythmias. What are the changes that happen in the lung? Lungs are very, very susceptible to these catecholamine storms, and this is typically called as a neurologic pulmonary edema. So what happens is, when we talk about the hemodynamics, the left-sided heart pressure, it exceeds the pulmonary pressure, causing a temporary halt in the pulmonary blood flow. This further escalates the damage to the lung because the exposed lung tissue is now injured, resulting in interstitial edema, alveolar hemorrhage, and this combinedly is known as a neurogenic pulmonary edema. So declining function of the bronchial submucous gland or decreased function of the cilia, which is because of the decreased perfusion to the lung, because of the neurogenic pulmonary edema, this further leads to accumulation of mucus in the dependent lobes of the lungs. So in 2017, to overcome such problems, the Indian Society for Critical Care Medicine came out with a position statement, and this has been recently revised in 2022. And most of the talk further, which is based upon selection of the donor and management of the donor, will be based on the recommendations given out here. The whole point was, why do we need these sort of guidelines to be put in place? And why it is needed is because of these 3 points. One, for timely identification and early referral of potential organ donor to the staff coordinator. This is the first clinical trigger, and any patient who has a GCS of less than 4 becomes an identified potential brain donor. Next step is the intensivist gets involved, and he is the leader of the team, which looks at the prompt application of donor care bundle, rapid assessment of the marginal donor so that it can be optimized into becoming a standard criteria donor. And lastly, using the transplant coordinators, there's a lot of communication, a lot of documentation, and a lot of implementation of protocols which need to be done to make sure that 3 things happen. And what are these 3 things? These 3 things are primarily improved identification, improved referral, and improved evaluation of a potential brain dead donor. Depending upon all these factors, we saw that there are 3 types of donors: a brain dead donor, donation after circulatory death, and a tissue donor. But then each donor can also be classified into either a standard criteria donor, which is a donor less than 50 years old who has suffered a brain death due to an isolated traumatic brain injury or a medical condition like a stroke. Or it could be an extended criteria donor where the donor is above 50 or maybe above 60 years of age, or between 50 and 60 years of age, with at least 2 of the following: from hypertension, cerebrovascular accident as the cause of brain death, or a pre-retrieval serum creatinine of more than 1.5 milligrams per cent. In spite of these, there are few donors which you will not touch. And who are these donors? People who have malignancies like a metastatic malignant neoplasm, acute leukemia, acute lymphoma, melanoma with less than 5 years of follow-up, pulmonary microcytoma, multiple myeloma, which is in progress, or serious infections like severe infections, intracellular pathogens like Listeria, trypanosoma, untreated or unknown origin infections, febrile meningoencephalitis of unknown origin, febrile encephalitis of viral origin, fungus or other opportunistic infections, and then infections with no treatment, such as rabies, or infections like dengue, which are still in their transmissible period and can affect the recipient as well. These are the absolute contraindications. Once the absolute contraindications have been ruled out, you need to assess the donor from a general perspective. And when we concentrate on the lung, apart from all the blood tests that are done, the heart evaluation, kidney evaluation, specific to the lung, the most important tests that need to be done are an ABG, a sputum or a bowel test, a chest X-ray, and of course, a bronchoscopy. Nowadays, COVID has become a standard protocol in most of the states, and it is required for not only this donor, but also the recipient and the donor, the recipient family to be tested for COVID as per the latest guidelines. Once we have done the lung assessment, what we need to do is we need to establish whether the donor fits into a particular criteria. And what are these criteria? Either it can be a standard donor criteria, such as age less than 55 years of age with ABO compatibility, a clear chest X-ray, PF ratio of more than 300 with an FiO2 of 1 and a PEEP of 5, less than or equal to 20 pack year smoking history, absence of chest trauma, no previous surgery, no aspiration, no secretions on the bronch, or sputum examination being good. Sometimes with sicker recipients, we need to go for an extended criteria donor where the age is more than 55, PF ratio might be slightly low, smoking history may be there, and there might be absence of history of lung disease or a mild asthmatic donor. Depending upon these things, appropriate decision has to be taken depending upon the recipient as well. Few slides on management of the lung donors. So the management can be divided into different categories. I'm not going into the specific management or overall general management of the lung donor. I'm talking only about the lungs, and this includes ventilation management to keep the lung hygiene good, management using a bronchoscopy, hemodynamic management, and few things such as early corticosteroids, use of thyroxine, and appropriate fluid management. Why this management is required? Because there are certain ischemic times for each organ. And you can see that the heart with ischemia of less than 4 hours and a lung with permissible ischemia of less than 6 hours becomes very susceptible to injury post-brain death. That is why it is important to have a good donor management strategy in place. The most important thing over here is the ventilatory management. As you can see in the cartoon, you have to avoid inadequate tidal volume also, and you have to avoid overinflation also, which can lead to damage or which can lead to things like atelectasis, hypercapnia, or inflammation in cases of an excessive use of PEEP. So the ideal strategy is use an FiO2 of 40% to ensure that the PaO2 is more than 100 with the SATs of more than 90%, PCO2 between 35-40, maintain a tidal volume of 6 to 8 liters, a PEEP of 5 to 8, and do recruitment maneuvers every 2 hours. Flexible bronchoscopy is very important. It needs to be done early into these cases, and then you stay away from it. But yes, if there are secretions, if there is any doubt, also have a low threshold to repeat bronchoscopy in a donor management. And the important point is not only to just go and suck out and do a BAL, but also to assess the mucosa, to assess the changes because of the neurogenic pulmonary edema, to make sure there is no repooling of secretions, to look at the secretions, look at the type, texture, volume, and where these secretions are located. Anti-infective therapy also plays a major role over here. And here, the most important point is that you need to use therapy based upon the site of donation, because you need to cover for nosocomial infection and not for community-acquired infection. So both gram-positive and a gram-negative cover is required. But yes, the use of nebulized antibiotics in these cases is still controversial. A standard protocol has been given out. It is called as the SWORT protocol because simply it came out from San Antonio, and it is the San Antonio Lung Transplant Protocol. I'm not going into the details of this, but this has given out clearly how, depending upon the time from identification of the potential donor in the first 2 hours or and after that, the ventilation strategy, the bronchoscopy strategy should be kept in place to make sure that the lung comes out in an optimal health and every lung becomes usable rather than maybe about 20% of the lungs, which are standard usable. The latest kit on the block is ex vivo lung perfusion, or retrieval of a lung, placement onto a machine system where the lung is ventilated, where the lung undergoes perfusion with a special system or steam solution so as to correct the electrolyte imbalances, so as to maintain oxygenation, do away with hypercarbia, and dry out the lungs to make sure that these lungs are not boggy. These lungs can be kept on this machine for about 4 to 6 hours. This also helps us to make sure that all the transplants are done in an elective manner and not as an emergency. With this, I'd like to conclude by saying that lungs are the most vulnerable of the transplantable organs. With patient-informed, carefully tailored management strategies, more lungs can be recovered, and communication and trust are critical elements in liaison between bedside clinicians and the transplant team. Thank you so much. Remember that the survival of transplanted organs depends heavily on the pre-donor and donor management protocol implementation. With that, I'm happy to share any of the questions that you have, and let's proceed with the panel discussion. Thank you.
Okay, thank you, Dr. Apar, and also Dr. Puri for your insights into this lung transplant. And we are overwhelmed by that, by your experience that happened in Junagadh, and hope that this spreads all over India, because as I said, actually the scene is quite dismal. So I think I will start discussing in this panel discussion the time from which basically we various certified deaths, and then we go on to the lung transplantation. So we will go serially step by step, because we are also discussing challenges here, in fact, that we have. And actually the most common challenge that I feel, because I've been involved, of course, it was discussion of this organ transplant whenever there is basically a patient who's serious or is organ death. It's about brainstem death, and it is good that actually we have got Dr. Shobhan also Roy, because what happens is that when you ask these patients that your patient is brain dead, they have got a doubt, and then when you also start discussing the organ transplant, they think that we should try more. They don't understand that once the patient has gone into brain death, he cannot actually come back. So I think this is the first hurdle we actually face when we are having this conversation about organ transplant. So I would like to ask Dr. Shobhan Roy about that, what is brain death, and of whether that is legally accepted as death, and then who will actually certify, and then how to overcome this delay which happens, because there is a rule that it's to be done twice within about 6 hours, and there's also a committee that you have to refer to. So I would like to know about this of the brainstem death phenomena that has to be certified, and then only you can ask for retrieval of the organs. Is Dr. Shobhan Roy? I think Shobhan, are you on mute? We are not able to hear your audio. Yeah.
Is it audible?
Yeah.
Thank you, sir. Thank you for selecting me. Thanks to CCI. So, sir, the main thing is that to the common people, we should explain each and everything. It's very nice. You people are doing very good work, sir. To the common people, we have to explain each and everything, the pros and the cons. Okay, sir. Then the from the forensic point of view, and then the legal issues will not come up. So main thing, you have to explain the party. So what we are going to do, what is the brainstem death, what you people are going to do, this and that. Okay. So that's the thing. So brainstem death is nothing but it's deals where the cerebrum may be intact. Cerebrum is intact. Baki throughout the functionally there is some lesions over the stem. The loss of the vital centers are there. The central respiration centers, these are not working. Ascending reticular systems, these are not working. The patient is being kept in the ventilation. Okay, sir. So that is the brainstem death, sir. So if you see the brain death is being classified into cerebral death, brainstem death, and the whole brain death. So cerebral death, if you see, so we have seen this Munna Bhai MBBS. So there was one character. So that subject was having this cerebral death. His respirations, his circulation, all things were okay, but his sensations were not there. This brainstem death is that there the respiration and this circulation, these are not working. So we have to keep that patient on the ventilation, sir. So that is the brainstem death, sir. When you are removing that support, the person is going to die, sir. So that is the brainstem death. Now the thing, when we are going to who are going to certify that brainstem death, who are going to remove, when we are going to remove this support. So there are some selective persons are there who are supposed to verify it, who are going to report that yes, you can now remove this support system. So that is the thing. First one is your neurologist. One neurologist should be there. If there is no neurologist, then one neurosurgeon can be there. If there is no neurosurgeon, no neurologist is there, then one medicine expert, MD medicine expert, or a surgeon expert, or from the MD emergency medicine expert, they can certify. So these are, in one sense, that these are some of the recent amendments where these things are being put over there. Some one have asked about the recent amendments. Then in that team, one in charge of the hospital should be there. Then the treating doctor should be there over there. Another doctor should be there who will certify this. So this is the team who are going to certify it. Now the things, all these doctors should not be there. Main thing is that all these doctors should not be there in that transplantation team. In the transplantation team, all these doctors should not be there. That's the one thing. So this is the thing, sir, regarding this brainstem death, sir.
But I think if we see the transplants and also the organ donation, that usually comes from a bigger hospital where they got this facility of certification and all this. But I think chunk of deaths.
So there are a lot of forms there.
Pardon?
Sir.
And these chunks of death, in fact, takes place in smaller areas. In fact, and also because smaller hospitals. Apar, how much this would be hindrance basically to have because there's a delay of 6 hours, and then of course you can have it only in the bigger hospital while we are trying to harvest more and more organs. I think this actually what you call smaller hospitals or these smaller nursing homes where we have most healthcare activities spread in India. How can you bring them into this fold and also make it just much easier for them?
Yes, sir. Another thing is that each and every hospital, they can't go for this transplantation or this OT for this transplantation or reservoir of this organ donation.
That is the challenge. So, of course, I want to ask Apar because he has got experience, because you also must be knowing that all these organs comes only from bigger hospitals, as I suppose. And then, what's your experience about this?
So, as Dr. Shobhan was rightly mentioning, that all these hospitals, any hospital cannot do organ donation. They cannot allow harvesting by the transplant teams. So there are particular guidelines and regulations that have been laid. Permissions need to be in place even before a hospital can think about organ donation. And only those hospitals which have been designated by the state governments, by the organ, by the local SOTO, ROTO or NOTO, is allowed to partake in an organ donation program. So most of the times what happens is these small nursing homes, when they identify a critically, sick neurological patient who may be progressing towards brain death, they typically refer them to a higher center rather than managing this case with them. And once this patient comes to a higher center, which has the license for participating in organ donation, and the patient undergoes a brain death in that hospital, then of course it can become a potential donor and the talks with the family will start. An important point over here is it is illegal to transport a brain dead patient for the purpose of organ donation. That cannot be allowed. The patient is shifted prior to brain death with an inclination that provided good care, provided advanced therapy, the patient may be saved from progressing towards brain death. The entire focus is on managing this patient so as to save the patient's life, bring back meaningful life for this patient. But despite that, if the patient progresses towards brain death, then only organ donation can happen. So, as you rightly said, smaller hospitals face a much bigger challenge. Now, what we are seeing is many of these smaller hospitals, as you also mentioned, are becoming centers, especially for cornea transplants, special centers for kidney transplants, and also now coming up with liver transplants. Although thoracic organ transplant till now has not gone into the smaller hospitals, it is still reserved for the tertiary care centers. But yes, the other organ transplants are beginning to happen in the smaller hospitals. So I suppose in the near future, we might see more donations happening from these centers as well. So that's something that, the future will show us.
I can add one more point here, as Dr. Rajesh mentioned. There is also a concept of NTORC, which is called as non-transplant organ retrieval centers. So nowadays the license is available. I mean, you have to go through these various formalities which the government has set in. And if you fulfill those formalities, those small centers can be given a license, what is called as NTORC, which is non-transplant. They are not doing transplants, but those are the centers which have the license for organ retrieval. So if more and more centers join this NTORC and get this license, I think the organ donations would definitely improve in the state.
And also, even among these bigger hospitals that happen, I think that the transplant of lung is still low, because I seen and I also read in the media that then other organs were harvested, but then a lung was not able to be transplanted because of also various challenges. So, what are these points that thing just would be there? In fact, I would ask Dr. Chetan Rao about this. That even among all the harvested organs, we have some challenges. Do you need some lung also transplant pulmonologist over there who has to assess some protocol, or actually from that point of view, if you want to comment?
Yes, sir. So as you rightly said, out of all the organ donations, not every donor is accepted for lungs. So if you look at the data, it is only about 20 to 30% of the times the lung is harvested from potential organ donors. Because previously people were sticking it to the ideal donor criteria. And with as in how we progress with the number of procedures and the lack of donors, we have moved on to extended donor criteria. So on a gross basis, when you want to assess if you are taking the lungs or not, first thing, the PF ratios. Previously, age was considered 55 years as cutoff, but now up to 70 years is also accepted. And the major point is a PF ratios of more than 300 and a clear radiograph. So if it is a bigger center, sometimes they give you a CT chest, but otherwise also if there's no obvious abnormality on a chest X-ray, like a major consolidation or a pleural breach, pneumothorax, or a large contusion, fracture ribs, then you can still go ahead with the chest X-ray also. And once you confirm that the PF ratios are good and the radiology is good and it's a good age, you also have to look at the pack years of smoking, but which is not so to be true in Indian scenario, because most of them would not conceal it to the family, and the family at that point of time will not be able to give us that history. So then we go ahead to assess the lungs. We do a bronchoscopy and see how the interiors are there, and that's how we proceed with the accepting the lung or not.
So, Rajesh, I'd like to add a little bit over here. So, you mentioned that the presence of a transplant pulmonologist at the site of organ donation, whether or not that is required, I don't kind of agree with that. I think donor management is a very composite thing, and the neurocritical team or an independent team which would focus, that would be an ideal situation on donor management, because it's not just the lung or it's not just the kidney or just the heart, but we are talking about a donation and retrieval of all these organs, saving about 8 to 11 lives from this one donor. So the protocol that needs to be done in a very holistic manner. The transplant nephrologist might want a lot of fluid going in with a lot of diuresis happening, but the pulmonologist will not want that to happen, because we want to keep our lungs dry. So in most of the organs, there is a very thin line between pushing a standard criteria, donor to an extended criteria donor. Just with a composite donor management, a holistic donor management, where the ventilation, where the fluid balance, the inotropic balance, the diuretics, and the anti-infective therapy is managed in a holistic manner, we can actually promote the health of all these organs till the cold ischemia time starts. So I think having individual specialists at that point of time might be a waste of resources, might create more confusion, rather than somebody who's trained in donor management needs to do this.
But Chetan, do you also see there is also a role of bronchoscopy during that assessment, because that would preclude a pulmonologist to be there for the lung harvesting? So is it necessary, and then what's the role? What's its role?
Yes, sir. As I said, definitely we do a pre-transplant bronchoscopy as a part of assessment of the lung. So when we do a bronchoscopy, we get a lot of information that we don't get in an X-ray or so. We actually look into the interiors of the lung. We look at the mucosa, the state of the mucosa. Is the mucosa healthy? Is it edematous? Is there any inflammation? Or sometimes you see some endobronchial lesions which you can't actually pick up on an X-ray or CT scan. And also you get to know the anatomy of the airways. If there's any supranumerary bronchus arising from the trachea, that would help the surgeon in some way. And the most important thing is to look at secretions. Most of the times, after like a day or two of intubation, you tend to see some central secretions, but central secretions after you suction out, if there is repooling of secretion into the airways, that is when we think of rejecting it or obtaining cultures. But if there is no repooling of secretions and oxygenation is good and the mucosa is healthy, and that is a good lung for us to accept. So definitely bronchoscopy helps us in assessing a donor lung, whether to take it or not to take it.
I'll come to Dr. Unmil Shah. And do you have any other organ preservation techniques? I know pulmonologist checks and balances, because we have just heard that basically there has to be pH electrolyte balance and this thing. So I mean, do you have some other organ preservation techniques for us pulmonologists to checks and this?
Yeah. So I mean, most of the centers still are using the ice box, what is standard across the country and across the world also. But now there are new technologies for organ preservation and transport available. To say, there is a FDA approved OCS technique, which is from Transmedics, where you can transport an organ. It's a portable normothermic mode of transport, where you can optimize the organ during the transport as well. The checks and balances from the pulmonologist point of view, I think, are very important as far as the centers, those who are still using the ice box, is that make sure you have enough extracellular solutions taken for lung preservation and perfusion. It is very important. Second, make sure, I mean, you are with the surgeon, make sure the antegrade and the retrograde perfusions are happening as per the guidelines and also at the pack table. The third thing is obviously the packing the organ, the lungs. There is a triple bag, method which is available and which has been practiced worldwide. And the pulmonologist, along with the surgeon, should make sure that the organ is packed very well and kept in the ice box. The main disadvantage of the ice box is that it's an unmonitored. We cannot measure the temperature of the ice during the transport, and sometimes the temperature can go below 2 degrees Celsius, or sometimes it can go even above 10 degrees Celsius. And it has been proven in the literature that either of these temperatures are detrimental for the graft function. So that is why the concept of carrying or having a newly better techniques to transport the organ and preserve the lung graft function. So there is a new box which is now available nowadays, and which has been studied from the Paragonics, which is called LungGuard, where you can monitor the temperature while traveling and keep it between 4 to 8 degrees Celsius. Obviously, there has been a Toronto paper which has also compared 10 degrees Celsius versus 4 degrees, and they have found that with 10 degrees, probably you can keep the organ for a longer period of time. Another, as I mentioned, OCS, which is still not used in India, but it's a Transmedics. It's a portable normothermic, method of lung preservation, where you can, optimize the lung as much as physiologically as possible. So I think it's the transport of the organ and the preservation of the organ is very important, apart from just retrieving the organ, because if you do not transport the organ in the correct manner, the patient is going to land up in the what is we called as ischemia reperfusion injury, which is called as primary graft dysfunction, which happens within the first 72 hours, and that PGD is one of the risk factors for the acute as well as chronic rejections. So I think from the pulmonologist, also the minute details about how are you retrieving the organ and how are you perfusing the organ, whether the specific techniques about at what height the bag has been, the perfusate has been kept, at what height, at what rate are you perfusing the organ, whether it is retrograde or antegrade. So I think these are all checks and balances which every pulmonologist at the donor site, at the donor retrieval, should be aware about. The small nooks and small points are very important to have a optimum lung preservation and transport.
And all of these techniques actually increase the preservation life of the organ. So
there are two trials. There were two trials which were conducted for the OCS, Inspire trial and the Expand trial. I mean, it's very fancy to have those boxes, but if you see the long-term survival as compared to the static cold storage, what we use, commonly most of the centers, and people still say that they have confidence in the eye still. So it is like there was not much statistically significant difference in the survival as far as the lung guard technology which was used, or the OCS which was used versus the static cold storage. So, but I think we have different challenges. I mean, in these all studies have been done in most of them in US, and in the US the problem is the distance covered is too far, from one center to another center. Like, for example, the OCS technique, what they used, they brought lung from Alaska to some center in US which was 4,700 miles away. Now, to have this kind of transport, yes, such type of technology is definitely going to be a game changer and disruptive in the field. In India, we don't have this kind of long distance retrieval still happening. But yes, another important thing was OCS has also been approved for extended criteria donor lungs. So basically, that can be a game changer from the Indian perspective, because we see a lot of extended criteria or margin lungs in India as well, and probably that might play a significant role in the future. But I think more data is required. But as of now, yes, the data found was PGD at 72 hours was 50% less in OCS as compared to static cold storage, but still the outcome was more or less similar. So I think a lot more data still required. But yes, I think this technology is definitely, hold a future, promise in the future, I believe.
And also recently I heard another term, actually, what we call breathing lung transplant, and I was quite intrigued about the technique. I have, of course, heard about beating heart surgeries, but I was intrigued about this, and there was also a press conference made to also say that we have got this technique and this is a breathing lung transplant. So can you just throw light on that, Apar? Is it something that basically you put the lung which is still breathing and you transplant, because that is what it means to you? But I don't think that is the case. It's just to also just preserve organ better. So if you can throw the light, because this is an intriguing term that I came across recently from one of the centers that are doing transplant.
Rajesh, as much as I respect the technology, and it's a beautiful technology to increase the amount of donors' lungs that we can utilize for transplantation, but the term breathing or beating lung transplant is just the pulmonologist peacocking in front of the cardiothoracic surgeons. Harsh is sitting over there. They like to talk about beating heart surgeries, but I don't think there's anything called as a breathing lung transplant or a beating lung transplant as such. Basically, what we are trying to do is we are trying to extend the ischemic time of this lung, and we are trying to improve the health of this lung. So the lung is mounted into a dome onto a device where it can be ventilated, where it can be perfused using specialized solutions which have a lot of albumin and a lot of molecular additives in that. It can be treated with anti-infective agents. We can make sure that the lungs are becoming drier. They are not boggy before they are transplanted. We can make sure that the PF ratio is good before the lung is transplanted. So what it does, it will give you an additional 4 to 6 hours time, additional 4 to 6 hours period, where you can decide whether or not this lung has improved enough to be transplantable into your recipient. And this ensures that the recipient does not get a bad lung, which will result in obviously inferior survivals post-transplant. Secondly, This will help to improve the health of the lung, leading to lesser complications post-transplant. Thirdly, as I mentioned, even logistically, it is a boon because organs coming in the middle of the night need not be transplanted right at that point of time. You can have this machine run, have the machine optimize the lung, and then all the surgeries are done electively. And this is the standard protocol which is being followed in Toronto, which is the largest lung transplant center now, that every lung that comes in goes onto the device and then transplant takes place. The problem with this, and Unmil was mentioning a lot about the transmedics, the OCS system. We have a unique challenge over here, and the unique challenge is the cost. Putting a lung onto
ask you how much it costs. Yeah,
absolutely, putting the lung onto the ex vivo system, even with the Indian rigs that Unmil's team Sandeep has developed, or we have developed at NGM, it will cost anything between 7 to 10 lakhs per transplant per organ which is put onto the lung. Now, the question that comes into play is twofold. One is, if the lung is rejected, who bears the cost? Two, if the lung is rejected, will the authorities allow you to discard that organ even after it has been allocated to that particular recipient? So these two are the things which have to be discussed with the authorities as an individual case-to-case base still. And no standard guidelines have come out from NOTO, which can be followed by each SOTO. So, like with Telangana and with Tamil Nadu, each time that we need to put the lung on an ex vivo device, we need to talk to the authorities, get permission that if the lung still does not look good at the end of 4 years, we are going to discard it. And it's a tussle every time. Talking about Transmedic, the module that we use, each time a module is used, and it's a one-time use module for transporting the lung, it is anything between 25 to 28 lakhs per use. So that's like absolutely another transplantation cost that the patient has to bear. So I think that is some of the unique challenges. No doubt it's a technology worth investing in, and once more and more numbers come into play, once we understand the technology better, once things can be indigenized, the cost is definitely going to come down, and then it can be something which should be used by every transplant center across the country. But till then, we need to be a little bit skeptical and a little bit careful about it.
And also, whether insurance companies cover this cost. So I have this doubt in mind. Suppose a deceased person had an insurance in his life, does it also cover his organ donation cost and something, or who bears this cost?
So two parts to your question, Rajesh. One, organ donation, as we have all said, it's a noble gesture. So there is no cost to organ donation. And recently I saw, a newspaper clipping, I think today's paper itself, where the high courts have given out a judgment that once a family agrees for organ donation, the bills will need to be put off and the hospital needs to bear the cost. Something to that effect, not clearly though, has come out into the papers today. The real question to that is, when it comes to insurance, not every insurance covers the cost of transplantation at all. Cost of transplantation, the preoperative evaluation and assessment, patient stabilization, many of the insurance providers will not cover this. And when they don't cover this, the cost of organ management or organ retrieval and organ transport is usually not covered by insurances. Very vast insurances. People, we've had patients who've had insurances covering up to 2 crores or 5 crores. These usually will do, but then again, you will have queries coming into you, which you need to answer. It doesn't come up in a straightforward manner. So to put it short, organ donor, no cost over there. There is no cost that any of the recipient have to bear in terms of getting that organ. There is no incentive that is paid to the donor family as well. And all these measures, all these checks have been put in place very specifically to make sure that an organ sale racket never comes up. People do not, create this as a business. It is a noble gesture and it needs to remain like that.
And Dr. Puri, we also heard Apar saying that most of the organs comes from the south, and we are from north. So what are the challenges that you face in this transplant programs, and how can we increase organ donation from north? What are the unique challenges that you have faced in this area of India?
Sir, the data is there that the donations are lesser in North India as compared to South India. They are not very significantly less, but yes, the governments are more inclined to for organ donations in South India. as well as in like Hyderabad, Tamil Nadu. But in North India, there are many taboos also. The religious taboos, the people not consenting, the pundits and all those saying that see the soul has to go to
Disfigurement of
the
the body.
yeah, that soul has to go in totality to the heavens or something like that. So, and convincing people, see, as our forensic expert was telling, that convincing a family that the patient is brain dead now, and we are going for a communicator goes to the family and says that we are going for an organ donation, or does the family wants an organ donation or something like that. In North India, the temperament is still not as great as the South, because if the family straight away says if the patient is dead, stop everything and give us the patient. We'll take them to maybe the cremation ground or to the native village or something like that. So North India has unique challenges, but still, because of the efforts, because of the meetings like this, the government coming to in terms to the organ donation planning, the NATO becoming more powerful and all those stuff, it is increasing. It is increasing day by day, but North has got specific challenges, which South has done better, I think.
Yeah, true. So we have had such problems, in fact, that they think that if it is disfigured, then it won't be accepted in the heaven or the whatever, and then and the body get disfigured. But then we have to tell them that it is all, there is also what we call a dignified way in which we would.
Yes. There should be a lot of counseling to the because we may add the religious angles also, that the first donation was done by that Rishi who gave his body to Indra for. So a lot of things can be done together, but then everybody should be on the same page, and money plays a very big role. Dr. Apar is telling about a legislation today that if the bill of the family who goes for the organ donation can be settled by the hospital, this will give a lot of boost to that family. Because see, we are telling that we are going for an organ donation. They know that this organ donation is a costly thing, and then if they have to pay 5 to 10 lakh rupees of the bill pending for the donor, it becomes really a mess sometimes.
See, Rajesh, I'd like to, ask a question over here, since we have a legal expert, and if you permit me, I'll make the question. So, is it possible, like we do for all our end-stage ILDs and end-stage COPDs, we start talking about transplantation, but yes, when they come to us in exacerbations, when they're very sick, we also talk to them about palliation, end-of-life care, and whether or not ventilation, ECMO, and strategies, if the patient is going towards a death over there. Similarly, when you have a neurological injury, you have a road traffic accident patient or a stroke patient, is it possible to start talking about organ donation right at the time of admission to these families and to these patients, or is it legally not allowed?
No, but apart, this also makes a little bit doubt in the patient, whether you're after his organs and whether you're going to give him optimal care. So there is a lot of gray area in what counseling straight away, and I think education of the relatives plays an important, I think, role in this, because if you start telling them right from the start, and thanks to those media reports and media hype about organ seal and all these things, I think there is some also problem in that. If you tell beforehand, even when we tell them that if there is also brain death, they would then often still request us to try our hard, and do not, they just won't accept that this patient will never come. And so this is I think the problem. So that is what has happened, in fact, that you're more interested in his organs than managing the case. This is what we see in India, and as I say, actually also education plays an important role, I think, in that.
So yes, what does the law say about that? I mean, I totally agree with you. Practically, it is impossible to do that. But what does the law say, or is it mum?
Sure. So thank you for the question, sir. The thing is that you have to take your whole effort. You have to treat the patient. Okay. Main thing is the documentation is the must. The patient is coming. You are taking all the steps to patient. Okay. You have to document first. You are making your whole effort to prevent the patient from death, to check the patient from death, but then you have to document it first thing. Okay, fine. Suppose this is a road traffic accident case, road traffic incident case. Okay, sir, you are seeing the condition of the patient is not so good, not so good. You have kept the patient in the on ventilation. You are seeing that the condition of the patient is not good. You have to explain the party. You have to explain the patient's party. See that the condition is not so good. Next option is that you have the opportunity that you might you can donate the organs of the subject. Now the thing is that from our forensic point of view, see, this is a road traffic incident case. Okay, so this is a medical legal case. So medical legal case, if the patient is dying, then the postmortem will come. The police will go. There will be a police inquest will be there. So now the government of India, as per the government of India, now the postmortem thing, now this is being done on the earlier this was being done only during the daytime hours. Now this is being made 24 hours. During the night time also, this postmortem can be done. So if suppose this case is occurring over there, so if there is this communication there is nice communication with the home department, there is the police, with the next is with the forensic department, those who are doing this post-mortem. Okay, so where the patient is there, the forensic people will come over there, the police will come over there, they will do the inquest over there. Then suppose that is the case of your head injury case, you people are dealing with the lungs, so only the brain is being injured, lungs is okay, all right. So police will do their inquest, the inquest is being done, then the forensic people will come, they will see, okay, does the brain is being injured, so it's okay, the lung is all right, you can take the lungs for the transplantation or for the donation, you can take away the lungs. So that's the thing. So that's the new concept is coming. 24 hours of the night autopsy is also coming. It is the order right now. It is the order from the government of India also. So that's the thing.
Yeah, but most of these cases, accident would also be medical legal cases. So if you would wait for postmortem and also wait for also police people to then also come and also certify, Brendan, does it cause a much I think delay, and then it can be hurdle in fact, and of whether we can do something to avoid this, this sort of critical period, which actually goes also wasted.
Sir. So
is there any amendment on that?
Sir, there's the thing. It is there. So police can come and they will do the inquest over there. So there's the what I will say. There's a rapport with the police department, or the thing is that they have also this order also. They will come. They will also communicate with you also, sir.
And now once this is also retrieved, there is also important aspect also transport. So Apar, do you have? What are the critical steps? Now, of course, we do see this green also corridors being there, and there is awareness about, there is also a critical time to which you have to just transport the organ to the recipient. So, what are the critical steps that has to be taken into consideration once it has been retrieved?
I think, Rajesh, that is a very pertinent question over here. That organ transport, fine, retrieval, we've all discussed about the steps, how the organ needs to come out, the checks and balances, how we need to make sure that the organ is in good quality, but it, yes, needs to reach the transplant center. I think there has been one recorded incident where there was a flight crash and the organ couldn't reach. But except for those extraordinary circumstances, most of the times we need to find ways of getting the organ into the recipient OR as soon as possible, unless, of course, you're using the transmedics or you're planning to do the ex vivo systems. Now, in India, again, we face a particular challenge over here that not every patient is affordable to get the organ, especially if it is from out of state, using a charter flight or using an air ambulance. So most of our teams design to get the organ, if it is from another city or from another hospital, by coordinating the times for commercially available flights. The problem is when donations happen in B-tier cities or smaller cities or towns which do not have a nighttime airstrip, or where the connectivity to the airport itself will take about 3 or 4 hours by road and then take a flight. So these actually constitute a lot of problem. Many of the hospitals like Yashoda, Chetan is sitting here, they enjoy a huge in-house donation facility. So I think these hospitals are absolutely perfectly suited to have a large, vast variety of multi-organ or multi-visceral transplant programs, because in-house donation obviously not only is the best way to optimize the health of the donor organ, making sure that the recipient survival is great, but also it offers advantage to that particular hospital in terms of the first refusal policy. If an organ is donated in your hospital, you have the first right of refusal to any organ, and then only it gets added into the state and into the national pool. So looking at the logistics from a transplant team starts right when the local SOTO or the ROTO or NOTO sends the alert message that there is an organ donor available, or a potential donor, I should say, available in any hospital across the country. We need to look at the logistics of sending our retrieval team to that particular hospital. We need to look at the logistics of how the thoracic organ teams, if the heart and lung is going to different teams, is going to coordinate with the liver team. Of course, the kidney team and the hand team or the bone team won't make much of a fuss. They have a huge long ischemic period available. But the usual coordination is between the thoracic organs, the heart, lung, and the liver team, because the timing of cross clamp needs to be appropriately managed so that the heart takes the least amount of it in terms of ischemia time, is able to reach the airport right on time, and is able to get into the recipient OR, followed by the lung, and then looking at the liver. So I think transport of the organ plays a critical role over there. Then we do not have facilities to store these organs, especially when we are traveling with ice boxes or when we are traveling with the 10-degree box. Harsh would have faced the same problem. We don't have designated spaces in our crafts to place these. The Transmedics OCS system has been designed beautifully. We've all seen in the flights those trolleys where the crew stores the food and stuff. So the OCS, the Transmedics, has been designed to perfectly fit into that space, and it can be easily pushed into one of the trolley spaces, and the organ is safe. The organ box is safe, and it can be nicely stored. But all the other boxes need to travel as a passenger. You need to book an additional ticket for it, and it travels on the seat right next to either the surgeon who is retrieved or the coordinator who is traveling with the organ. And once you land, of course, yes, now the police in all the cities cooperates. And this all started from Chennai, that the first green corridor was made for a heart that was transplanted to Malar Hospital, and I think this was in 2016. And now this is following suit in every other city, where green corridors are made for getting the organ as soon as possible from the airport to the hospital. What we are recently testing out is we are collaborating with IIT Chennai to manage a drone transport, wherein we've done one heart as a pilot, and we were able to use that heart. So that was put out into the media, but we are looking at transporting the lungs also and the other organs from the airport to MGM hospital, so that what even in an ambulance takes about 18 to 20 minutes can be done in a very short span of about 7 minutes using that drone.
And I think we can have what we call a dedicated organ air ambulance, which can be stationed, and basically this could be a part of CSR activity. In fact, maybe initiated by NOTO or somebody, so that there is no need for finding this thing at the time whenever there is this problem. And I think in there's a context, Dr. Puri, I would ask you whether, of course, we need some national lung transplant program or some policies that would actually attain this thing much more further and would actually increase this organ transplants.
So, see, the point is that India, the live donor transplantation in India is much sorted. Like we see in liver, we see in kidney. But to contrary to the fact, the cadaveric transplantation is still not sorted. The central agencies like NOTO and SOTO and ROTO do not have that tooth and nail to bring everybody on the same page. Now, as Dr. Apar was telling, when we did our first outstation retrieval from Nagpur, we were totally denied to carry that big fridge inside the aircraft because the size was huge. They were not geared up. So we had to call the Home Ministry and a lot of phone calls here and there. And then only we were allowed to travel on an Indigo flight. After that, we made an official complaint to the NOTO. And 3 months back, they did a aviation ministry meeting, and everybody from CISF to NATO to SOTO and state organizations were there, present there. And we made a policy for sizes of the boxes and etc. to be transported in these things. So the point is that everybody from the government to the NGOs to the local bodies, the big private hospitals, to the peripheral, to the central big institutional hospital like AIMS, PGIs, CMCs, everybody has to come on the same page that organ donation has to be increased. The coordinator should be posted in all these government hospitals. See, maybe like a hospital like PGI Rohtak sees more than 10, 15 deaths per day, or a trauma center like AIMS sees 10 to 15, 20 deaths because of road traffic accidents per day. But we see that organ retrieval from these centers, centrally equipped centers, is almost zero. So the government has to form these policies. The NGOs have to come in great contact. It should not be that the organ of a government hospital should go to God. A lot of policies have to change so that the chain of command is there with some central agency. They are in looking for, if no of the organs should go into the bin. If an organ retrieval has happened in PGI Chandigarh, at least somebody, Apar Center, KIMS Hyderabad, somebody should be able to take that organ and harvest in one of the recipients. Because, see, as Chetan was telling in the beginning, only 10 to 20 or 30% of the organ retrievals are thoracic organ transplant retrievals, just because of the fact that the teams are not able to reach in time. The ischemic time always exceeds 4 to 6 hours. So a unified central policy considering the central institutes like AIMS, PGI, and all those, and big hospitals like Medanta, Max, and all those have to be formed so that they can act as guardian institutes and increase the donation as well as recipient pools, so that we just want to help the patients. See, ultimately, what we are talking about is end-stage diseases like end-stage respiratory disease, end-stage renal disease. So I think everybody has to come on the same page, and then a central policy has to be formulated and executed.
Yeah, Dr. Puri. So I think that integration of all this has to be there, and there has to be amount of coordination, which also between the government hospital and also bigger hospitals, as you said, they're not doing it. And so I understand that. And also there is some additional challenge, Dr. Unmil, about heart-lung transplant. As against doing only lung transplant. So do you face any additional challenge in that?
Yeah. So I mean, nowadays, if you see in the last decade or so, the indications for doing a combined heart-lung transplant has dramatically gone down. Now, most of the indications are for the bilateral lung transplant. Currently, right now, the most commonest indication for doing a combined heart-lung transplant is probably a young patient with Eisenmenger, probably with a complex congenital heart disease, which is not amenable to repair. So what happens is, usually now, as we all know, that in India, even the donation rates are probably 0.8 per parts per million. It's even less than 1. And plus, here is a patient who requires more than 2 organs, 2 lungs and 1 heart. Now that increases the waiting list, waiting time on the list. And most of the time what happens is, like, suppose the institute where the patient is listed is not doing an in-house donation, and if there is a donor called somewhere else, the heart would go to a different center and the lungs would go to another center, and that's how usually the patient misses the chance. So I think the most the major challenge for doing a combined heart lung transplant is that if the patients where such patients are listed in that transplant center, if they have a robust in-house donation program, and as Apar told, and once you have an in-house donation program, the first allocation comes to the in-house recipient who has been listed, and you can easily utilize the heart and lung combined together. So that is one of the commonest challenges which such patients face, where there's a long waiting time on the list because the heart is allocated to a different recipient and the lungs are allocated. So that is the most commonest challenge what we are facing right now in India currently, as far as the combined heart lung transplant is concerned. Otherwise, I don't see any other, transport or surgical or intraoperative or post-operative. I mean, those things are pretty sorted out. But I think getting organs, combined heart lung to a recipient who is waiting for so long. Most of these patients are younger patients, so that is, very tough actually.
So, Rajesh, let me bring in a little bit of technicality over here when we're talking about a combined heart lung. And, Harsh is here. He'll probably speak a little bit more about it. The issue is getting these two organs together while the preservation solutions are different. And they're absolutely different in terms of their molecular structure. You need an extracellular, solution for the lung, and you need an intracellular solution for the heart. Plus, the quantity and the force by which they are perfused is very different. One very common complication in a combined heart-lung, what we see is Perfadex, which is typically the lung preservation solution, washes off the custodial from the coronaries in a heart. And this will, culminate in the heart not beating appropriately or not beating at all post-transplantation. So your combined heart-lung transplant fails a lot in this ways. So the surgeon has to be on his toes when a combined organ is being harvested. If the two organs are being harvested separately, it's very easy to transect and make sure that the mixing doesn't happen. But when both the lungs need to be harvested, and it's an en bloc harvesting, the surgeon needs to be very alert to make sure that the Perfadex is not entering into the coronaries. There has to be an adequate, LA cuff release to make sure that the Perfadex is flowing out from there and not going into, the coronaries. And or sometimes, Sandeep started using this technique. I think he should patent it and he should name it also, using a small cut section into the aorta itself before the origin of the coronaries to prevent flow of Perfadex over there. The custodial is only about a liter or so, but there is about 5 liters of Perfadex that flows in to preserve the lungs, to wash out all the clots and to provide good preservation for the lungs. And this, if it gets into the heart, will create huge complications in the post-operative period. So this one technical complication needs to be controlled and needs to be in the mind of every transplant surgeon who goes in for a retrieval for a combined heart and lung block. And this is one of the major things that can help improve the outcomes in the combined transplant.
So I think with this, we are just running out of, the time we just completed set allotted time to us, and it was really a very good also. And of course, we know that there are challenges, and I think we have to go a long way, and you all contributed in just telling. We have some few questions before we really, and I had promised that we will take some audience questions. One of the questions that has come to my mobile directly is, what is the mean, time that patient has survived? Because he said that initially it was very less, and now he wants to know what is the time of survival for these patients after the transplant. How many years? What else progress we have made in that? And I think that is quite a relevant question for the audience to know about this.
So I think it's very clear. If you look at the ISHLT data, which has collated the data over a period of, the last 2 decades or 3 decades at least, it clearly shows that over a period of time, there is an improving survival. So what started with about 3 years post-transplant survival in the 1980s, early 80s, is now easily, if I can put all the indications put together, is easily 5 years plus now. Now, when we divide the indications, the best survival, what we are seeing is for bronchic, cases with cystic fibrosis or bronchiectasis, which could very well be 7 years to 10 years and beyond that. I think the longest known survival is about 33 years from a case that was done in Toronto. And this was a case of cystic fibrosis, which was done as a child. And then the patient in the adulthood underwent another repeat transplant with an adult lung and is still surviving. But yes, even when we come to COPDs, the survival is 7 years plus. When we come to IIPs, probably IPFs and CTD-ILDs, if I put them in a single bucket, the survival is still, when you talk about a median survival, it is still 5 years plus. So on an average, what we can say is that, yes, the median survival is 5 years plus for most of the indications. And depending upon the indication, depending upon the timing of the referral, whether the patient has been referred in a sick condition or in a healthy manner, depending upon the age of the patient, depending upon the comorbidities, the outcome or the survival can be to any end. What we need to remember is that the organ does not come with an expiry date. So the patient actually normally is supposed to live his or her natural remaining life. What that natural remaining life is, nobody knows. What we are talking about is just observed statistics, wherein the median survival, yes, on an average, we can say is 5 years plus.
I just want to make a point here that Dr. Apar made a very pertinent point. The survival will depend not on the disease. Yes, disease has to do something with the survival, but the survival will definitely depend on the time of referral. If the time of referral of the patient is good, you get the patient in a good condition. If he's not moribund, there is no multi-organ failure. All the other organs are working well. The patient has an inclination to do a lot of physiotherapy, lot of exercise, optimization. He has a will to live. He will live for the rest of his natural life very comfortably. And the average survival, I guess, is 7.2 years by ISHLT criteria. So it's my humble request to all the pulmonologists, all the physicians listening to this, that a timely referral is the key for a successful transplant. Donor management comes after that, but the timely referral of a recipient is the key for the success of the transplant.
And I think we can end on a note, and actually there's a question which has come, and I think I can take opinion of all of you in that, and then we can basically end, because as this is already suspect, is how to bring down the cost of lung transplant, how to really bring down the cost of lung transplant, which is quite exorbitant, they say, as compared to other organs, So they got some relative who has undergone a kidney transplant, and they say this can be done in XYZ, and now you are saying that lung transplant will cost so much. So there is some aspect to it, and why it is high. And this is the question, which is actually it has come from audience, Dr. Harinder Thakkar from Gujarat, that how all of us can combine together to bring down the cost of lung transplant. I'll start with Dr. Apar.
So, Rajesh, I think that is a very pertinent question, and really there's no set answer to that. I think we all need to work towards it. A few of the pointers that I can put together is, I think timely referral will definitely bring the cost down. If the sicker the patient, the more they spend even during the pre-op stabilization. The post-op ECMO use becomes higher. The post-op complication rates become higher, and definitely the patient ends up spending more. So a timely referral, as Harsh was also talking about it, is the paramount step, or step number one. Step number two, I think, would be just the number of referrals. Once we start doing more numbers, once the turnover, as the corporate hospitals would call it, is higher, definitely the cost would come down. I think the consumables that is there is a set cost. The cost of the Perfadex, which is there, is a set cost. The cost of the post-operative antibiotics, nebulizations, the immune suppression, that is a set cost. But apart from this, what really determines the cost is the duration of the stay and the amount of physiotherapy that the patient needs post-operatively, whether or not the patient is able to cough and needs tracheostomy or not. So these are very small points which will decide whether the patient can be transplanted and discharged within the package duration, or they will need prolonged care. I think if we focus on this, if we focus on sending a healthy patient for a transplant, this can come down. And thirdly, I think governmental intent in terms of two patterns. One is, like, we are talking with Rajasthan government, we're talking with Yogi Adityanath in UP. So they are being very resourceful in setting up multivisceral organ transplant hospitals or transplant units in their states, where free of cost transplant, or the entire cost being borne by the government, is going to be provided. Or secondly, like what Tamil Nadu does, what Telangana does, there is a chief minister scheme where at least the patients who are below poverty line, who cannot afford the cost of these transplants, can get it done free, and the government reimburses the hospital where the transplant is done. So I think more of these legislative policies or more of these support policies from the government is required to ensure that the transplant is available to a wider majority of patients.
You want to add something, Dr. Unmil and then Dr. Puri?
Yeah. So I think most of the points Apar has already covered. Maybe few things just out of the box thinking that, when we have so less donations happening, there is always a long waiting time. Even if the patients are referred in that right transplant window, sometimes they'll end up in an ILD exacerbation, they'll end up in ICU, probably on NIV support or vent, and then some of them may even require an ECMO. Probably if we have more donations happening, that will cut down the waiting time on the list also, and then definitely in the long run might definitely cut down the overall cost of the program. Secondly, proper donor management is very important, because what happens is when you take marginal lungs which are not optimized, when you take lungs which are not been have not been optimized, and not properly well preserved or not transported, invariably such patients end up in PGD, then managing in ICU, then that actually prolongs the ICU care stay, with leading to multiple complications later on. So I think the donor management becomes the foundation of any transplant outcome, basically. So I think if you have that proper management also, that might also additionally in a long run cut down the cost. And I think, as Apar mentioned, that you have CM schemes and PM schemes, and probably even the insurance companies, probably if they start thinking about covering the transplants in the future, I think that would be a great benefit to the people.
Is Dr. Puri?
See, this is the most common question I get at the end of my presentations on lung transplant. So, sir, we have to understand, everybody, the common person, the doctors, the legislation has to understand that transplant is a high-end process. It is the utmost surgery a thoracic surgeon can done. It's the utmost medical thing that a pulmonologist is managing. So we put in our heart, soul, blood, sweat, everything in this thing. So money will always be the big factor running the transplant programs. So how the cost can be brought to a plateau level is when the governments always should come in forward, like the Rajasthan government is doing, like the UP government is now coming forward. They will give a sum of like 25 or 20 or 25 odd lakh rupees for a family who has to get a transplant done. And we are very much available and ready to do these kind of high-end surgeries free of cost, without even earning a single penny for ourselves. Because if we do 10 these free kind of things, like 25 lakhs from the 20 lakhs from the government, and the hospital is happy enough, we will be able to do it more for the richer public also, and from where we can earn money also. So it has to be a balance between the government schemes and the private hospitals earning also, because it's a high-end process. It would cost something. The consumables are costly, the puffer deck, the machines, ECMO, everything has got a cost. So everybody has to think, has to come on the same page that yes, it will cost exorbitantly, will be higher than the normal surgeries we do. But yes, if the governments and the private hospitals and big hospitals doing these kind of programs come in on the same page, it can be the service can be extended to much larger population than what we are offering these till this time.
So the whole point, Rajesh, is not to bring down the cost of the surgery. We don't need to work on bringing down the cost of the surgery. We need to work to make it conducive for the patient to garner enough resources and go for the surgery.
Yeah, I think that also because cost of transport would be just much more than I think your fees of that is. So of course, it is a minuscule part of that transplant, and with that heartening note that we are also able to operate free of cost, and we do have charity, and we're all charged up doing these noble cases. I think we have to end this webinar, and I would say that I actually enjoyed it very much. I actually learned a lot from all of you, in fact, and I just enjoyed it. Also, this thing, and I think we have to call it today because we have already overshot by 10 minutes. Actually, thank you all of you. I think Dr. Chetan had to exit because of an emergency, so thanks to all of you. Dr. Suri, Dr. Apar, Dr. Unmil, and also Dr. Rao, who was there to also consider also this thing as a medical legal aspect. Thank you very much and all the best.
Thank
Good
you.
night.